And I think at this time I can take my mask off, and Shannon is now social distancing at least 6 feet away from me. So um, at OSC, we are following all of the CDC guidelines on keeping our patients and our staff healthy. So everybody's still wearing masks when they're in our building. We are limiting the amount of people that are coming back with our patients, unless our patients have some issue, either remembering things, or there's a speech or hearing issue where they require somebody to come with them. We are really trying to protect not only you, but also our staff. We have most of our staff vaccinated. All of the doctors are vaccinated. And we know a lot of our patients are now in the process of getting vaccinated, but until everybody is fully vaccinated, the mandates change, we are doing our best just to make sure that we sanitize every room before and after another patient comes in. We're limiting the number of people that are coming back to our exam rooms, and we're making sure that if we want to make things easier as far as getting into your appointment or making an appointment, we have mobile check-in, we have online appointments. So anything that does not require being face-to-face with somebody, we're really trying to make sure that our patients can get in to these things. So you can rest assured that OSC is doing everything and probably more to keep everybody safe. So the reason we're here tonight is something that's that I'm very passionate about. One of my favorite therapies for my patients, and one of the things that I feel are the most effective treatment for a lot of the conditions that I see is spinal cord stimulation. In addition to what we're going to get into tonight, which is spinal cord stimulation, I also want to talk about, what else are we doing in the pain world that, when you come into OSC, what else do we have to offer besides this stimulation therapy, which may seem kind of daunting, but eventually, if a lot of the more traditional or less invasive or more conservative options fail, it's nice that patients know that there is something more other than surgery that can be done. So one of the reasons why spinal cord stimulation came into existence was because traditional back pain was fairly simple to diagnose, not always easy to treat, but most of the time general back pain was due to degenerative disc disease or arthritis in the spine, very similar to what goes on in the rest of the body. When cartilage wears out and joints become more bone on bone, movement becomes more difficult, we feel stiffer, and our day-to-day activities are significantly limited. Well, also in the spine, it's where most of our nerves and information travels through to get to our brain. It's where the nerves that control our movement in our arms and legs. It's where pain impulses from the arms and legs travel to the brain. It's where all of our sensory information is processed. And so a lot of things occur in the spine that can't really be correlated to a joint like a knee problem or a shoulder problem, where a lot of different, therapies or treatment options have to be tried in order to get things under control. So when you're looking at spinal pain compared to joint pain, it's not just arthritis, it's not just mechanical pain. You're also looking at nerve pain. So nerve pain is very difficult to treat. Oftentimes, the only thing effective for nerve pain is medications. And unfortunately, oftentimes that medication is an opiate. Well, over the years, we've realized that opiate therapy is not always the best option for patients, not only short-term, but also long-term, not only because of the risk of addiction, but because over time it loses effectiveness. Higher doses are required, more side effects occur with higher doses, and ultimately, even at the highest doses, pain relief can stop and patients just are not satisfied with their care. One thing that's really been effective in managing both nerve pain and mechanical pain or arthritic pain has been spinal cord stimulation. And so I'm really excited to talk about that tonight. One of the ways we describe how back pain can feel for a lot of people is some people have just back pain, or they describe it as aching or stabbing or sharp. And some people have leg pain where they describe it as shooting or burning or numbness or tingling. And there's a lot of unfortunate people that have both, where they have chronic back pain and a pretty significant pain in their legs. So the combination of the two can be pretty significantly life altering and really reduce the quality of life, reduce function, and increase the need for medications. Well, we have come up with a therapy over the last 40 years that's proven to be extremely effective for not only pain of arthritis or degenerative disc disease or pinched nerves or spinal stenosis, but even after you've had multiple back surgeries. It could be 1, 2, maybe 5 back surgeries, and you can have just simple incision in the spine to open up the spinal canal for stenosis, like a laminectomy, or you could have pins and rods and all sorts of spinal hardware. It really doesn't matter. The beautiful thing about spinal cord stimulation is that this therapy is going to treat and manage all different types of pain. So moving on, a lot of times when patients first come in, we really want to get a gauge of where they stand as far as their pain, what activities have they had to give up or restrict because of their pain, and if everything worked out for the best, what things would they prioritize as being the top 2 to 5 or 10 things that they want to get back to. And so this page is simply just a list of very, very common goals or outcomes that our patients want to see, whether it's being able to play with grandchildren, being able to stand up for more than 10 to 20 minutes at a grocery store, or go to a concert, or not having any issues when they're intimate with their spouse, or yard work. I mean, a lot of folks, especially once the weather starts getting better, they want to go outside, they want to be active, and they know that maybe because of their arthritis, they might pay for doing certain things. And in the past, they may have managed that with taking tons of ibuprofen or tons of Aleve, or maybe half a bottle of Tylenol before doing yard work, and then again the other half bottle after they're done doing yard work. So those types of medications are great for now and again use, but for day-to-day use and for managing your quality of life for the later part of life, not always the best option. As kidney function and liver function starts to decline, we really like to avoid the use of medications if possible. So I like to look at this page because almost everything that's on here is something that I think spinal cord stimulation can improve. Oftentimes our patients come to me, they've already tried a million different things, whether they've seen their primary care doctor, they've seen orthopedics, they've seen pain psychology, chiropractics, physical therapy, they've tried multiple medications, somebody may have mentioned shots or pain pumps, whatever the case may be. These may not be the best option all the time for everyone. Now, if you have neurologic changes where you have a foot drop and you're getting weaker and weaker and you're losing bowel and bladder function, of course, we're not going to recommend something more conservative. You're probably going to be a good candidate for surgery. But if there are no red flag findings when we examine you, and your main complaint is pain, not loss of neurologic function, then of course, the therapies that we'll discuss tonight, whether it's radiofrequency ablation or spinal cord stimulation, may be right for you. So the first thing we're going to talk about is radiofrequency ablation. The second thing, of course, the main part of our talk is going to be spinal cord stimulation, but oftentimes patients will come in and we'll review their case, we'll discuss different treatment options, review their medications and talk about changes that can be made. And sometimes even after I've made a full review of their case, discussed treatments, they'll say, well, my aunt or my grandmother or my sister or brother told me that I should talk to you about burning my nerves. I'll say, well, that's a good option, and I'd be happy to explain that more to you down the road if that becomes an option. Well, you don't have to wait until your appointment with me or after a couple of visits to find out more about burning nerves. We can talk about it right now. That process or procedure is called radiofrequency ablation. And it's a really useful treatment for people that have spinal arthritis, where the way they usually describe their pain is that they're finding that they can no longer stand and walk for long periods of time. They go to the grocery store and they really like to lean on that shopping cart. And if they stand for more than 5 or 10 minutes in one spot, they have to sit down. Or if they're doing dishes, they have to lean on the sink. You hear these different complaints all the time. And the common theme in all of that is the source of that pain, and that's spinal arthritis. There's structures called discs, which provide cushioning between the bones of the spine. But then there's also a joint on either side of the vertebrae, which conjoins with the joint with the vertebrae above or below, which is useful for restricting excessive rotation. It helps with reducing excessive bending over, excessive bending backwards, and essentially acts as a protective mechanism for the spinal canal. Well, over time, the cartilage inside of those joints can wear out and range of motion can become more difficult, and patients will experience those symptoms that we talked about, where they can't stand or walk for an extended period of time. Well, radiofrequency ablation is a way to actually numb, and then if the numbing is effective, to then cauterize the nerves that are responsible for transmitting that pain signal from that joint back to the brain. And so when you have arthritis in those joints, for example, if you have arthritis in your knee or your shoulder or your hip, if there were nerves that you could put to sleep to block that pain from ever reaching your brain, you would do that in a heartbeat. Well, thankfully in the spine, we do have that procedure. The nerve that supplies sensation from that joint is called the medial branch. And thus these blocks that we do for arthritic pain in the spine are called medial branch blocks. The goal of these blocks is to determine if the patient achieves at least 50 to 75% pain reduction, improvement in standing and walking tolerance, and improvement in quality of life after we numb those nerves and put them to sleep, either temporarily or for several weeks. The thing about the blocks is that that's not intended to provide long-term relief. And oftentimes, even after discussing the procedure with a patient, they'll come back and say, it worked great, but it only worked for a week, or only worked for 5 days, or only worked for 2 weeks. The goal of the blocks was not to give you long-term pain relief, but it was to determine if your pain is predominantly related to the arthritis in your spine. And so when we block that pain signal going from that arthritic joint back to your brain, and you achieve at least 50 to 75% pain relief, we know that a large majority of your pain is coming from those arthritic joints. And so in that case, if you do achieve really, really good pain relief, the next step would actually be to cauterize the nerve that supplies that joint. That procedure is called a radiofrequency ablation. The radiofrequency part of it is the energy that's used to basically cauterize or melt the coating of the nerve. You imagine if you strip the insulation off of a wire, it's not going to transmit electrical signals very well, or radio signals, or whatever is traveling through the wire. You're basically melting the insulation of the nerve. And when you do that, you're not cutting the nerve, you're not doing surgery. If it doesn't work, you're not really left with any long-term problems. And the main drawback of this procedure versus surgery is that over time, whether it's 6 months or 12 months or even maybe even longer, eventually that coating will return, and that nerve may or may not be able to transmit that pain signal back to the brain. The good thing is that it's not surgery. It's done in approximately 15 to 20 minutes in our office. It's minimally to non-invasive, other than the lidocaine injection and doing this procedure under x-ray. There's no incisions, there's no cutting, there's no downtime. You can go back to work the same day. And in that regard, I feel like radiofrequency ablation is one of the best treatments that we offer, because how prevalent spinal arthritis is. Getting into the meat and bones of this talk, I'm really excited to talk about spinal cord stimulation, because it's one of the few things that I do where the pain relief is oftentimes immediate and quite dramatic. These are folks that have, like we talked about earlier, have had multiple surgeries, multiple epidurals, multiple injuries to their back, degenerative disc disease, arthritis, pinched nerves, herniated discs, spinal stenosis, whatever the case may be. In my opinion, this therapy is effective against all of those. The reason being is because spinal cord stimulation works completely differently than anything else we have. If you've heard of a TENS unit, you know that a TENS unit modulates electrical signals on the skin and in the muscles to basically mask the pain that's coming from the periphery. It's not really penetrating deep to the nerves of the arms or legs. It's not really treating any pinched nerves in the spine or any spinal cord injury. The effectiveness of TENS basically comes from what we call the gate control theory, where if you provide a stimulation to an area of the body that overrides the painful stimulation, your body is going to pick up on that other stimulation. Well, spinal cord stimulation works similar to a TENS unit, and oftentimes people call it a TENS unit on steroids, but really it's working on a completely different mechanism. The spinal cord is essentially the gatekeeper of all the signals that are coming from the lower back and legs. Or higher up, the spinal cord also is the input for all the signals from the neck and the arms. Well, when you're able to stimulate a very specific area of the spinal cord, you can basically close and open gates that control whether or not certain pain signals can pass through and which signals that are appropriate signals like muscle control or normal pain actually get to pass through uninhibited. And so what the stimulator does is it actually acts as a roadblock to abnormal or chronic pain signals while allowing normal signals such as muscle control, normal pain such as stubbing your toe or a broken bone or stepping on a tack to pass through unimpeded. I know a lot of patients have concerns that if you're blocking my pain in my lower back or legs, how am I going to know if I hurt myself? Or same thing for the neck and the arms. Well, the good thing about the stimulator is that it selectively blocks abnormal pain signals, or what we call chronic pain, which are different types of nerve signals than what an immediate or new pain signal is going to pass through, or a muscle control signal is going to pass through. So it's not going to make your legs weaker. It's not going to affect how you walk. In fact, if all goes well, you should be able to stand up straighter, walk longer, walk better, sleep better, and have better control of your pain. What we're seeing on this page is a lot of the equipment which we use. Those silver objects in the middle are the batteries that are implanted in underneath the skin, very similar to a pacemaker for cardiac conduction issues. This is essentially a pacemaker for abnormal pain signal conduction issues. And so the concept is very similar. Electrical signals that travel to the heart and the brain, both can be controlled very precisely using these tiny batteries that are essentially supercomputers in a very, very small package. For spinal cord stimulation, there are wires that are either surgically implanted or percutaneously implanted through a needle into the spinal canal, then attached to the battery. Everything is placed underneath the skin. You're essentially waterproof, and you can go diving if you want to. You don't have to worry about your battery falling out after it's put in. So what types of conditions does spinal cord stimulation treat? We already talked about folks that have had herniated discs or pinched nerves or spinal stenosis, but there's also a condition called failed back surgery syndrome, where if you've had 1 back surgery, 2 back surgeries, or 5 back surgeries, oftentimes it may look like there's something that can be fixed. Other times you get an MRI or a CT scan after surgery and everything looks perfect. There's no hardware abnormalities, there's no new pinched nerves, there's no stenosis. The original issue that the surgery was performed for is treated, meaning if you had a herniated disc and that disc is removed and pressure taken off the nerve, or you had spinal arthritis causing narrowing of the nerve canals and that nerve canal is now widened and pressure is taken off the nerve. Whatever the case may be, the surgery is essentially anatomically successful, but unfortunately the patient continues to have chronic pain and a distribution correlated to where the surgery was performed. And oftentimes there's no explanation for that. It's just unfortunately how some people end up after back surgery, neck surgery. And there is a medically recognized diagnosis for that, and that's called either failed back surgery syndrome if they have pins and rods placed in their spine, or post-laminectomy syndrome when someone has had a laminectomy where a small incision is made in the spinal canal to alleviate pressure on the spinal cord or the nerves for spinal stenosis. Well, oftentimes the only treatment for those people are either opiates, nerve pain medications like gabapentin, Neurontin, Lyrica, Cymbalta, or epidural steroid injections, which may provide some good benefit for short periods of time. But over time, even cortisone can have side effects. It can weaken bones as we get older. And we like to use these treatments judiciously, um, and avoid doing too many of any of those treatment options on any one person. So if you come in to see me and we discuss your pain, and it looks like, you've tried multiple conservative therapy options, you've already tried physical therapy or had shots, or you've had radiofrequency ablation, and your pain scores are higher than a 5 out of 10, and you describe your pain as aching in your back, shooting or burning or tingling in your legs, you might be a perfect candidate for this. So the beauty of spinal cord stimulation is that it's not just the new kid on the block. This has been around in some form for 40 years. And if you really know the history of how electricity has been used in medicine, it's been around for thousands of years. Ancient Egyptians and Greeks used certain kinds of fish that had electrical conduction characteristics to treat patients with chronic migraines, chronic leg pain, chronic arm pain. And so the use of electricity to treat pain has been around a lot longer than spinal cord stimulators have been around. But in its current form and its FDA-approved therapy characteristics, it's been around for about 40 years. It has dramatically improved over the years. Initially, these devices were pretty large. They were tough to implant underneath the skin without the patient feeling it all the time. They were not rechargeable. They didn't last. The batteries did not last very long, and the therapy was not reversible. Meaning, once you put it in, it was tough to remove. Now, all spinal cord stimulator therapies are FDA approved. There's no medication involved, so if you're having a really good day, you can turn down your stimulation and feel it less. Or if you're having a bad day and you're feeling more pain in your back or more pain in your legs, you can turn it up. Now, oftentimes, patients can either have what's called paresthesia stimulation, where they feel some tingling or vibration in their legs or back, or they can have what's called paresthesia free, where it just provides pain relief without the patient feeling any sensation whatsoever. Every patient is a little bit different. Some love that feeling of tingling and vibration. Some don't like it, and other people love the feeling of having pain relief without feeling anything else. Everybody's a little bit different, and the great thing about the stimulator is that you have the variability of trying and using either one or both concomitantly. What we find in our spinal cord stimulator patients is that if they've been suffering with chronic pain for years and they've tried multiple medications, they might be on a ton of opiates, they might be on a ton of anti-inflammatories or Tylenol, they might take a ton of gabapentin. Well, before the trial, we might cut back on a little bit of that. We're not going to completely eliminate those medications. But then after the implant, if their pain is dramatically improved and significantly improved, we will work on getting you off of those medications. And so not only is the stimulator a non-drug therapy, it also helps eliminate a lot of the medications and drugs that patients are currently taking. How spinal cord stimulation works, I already touched on this a little bit, but it is a implantable device that has wires that are coming out of the battery, traveling into the epidural space in the spinal canal, which rests just above the spinal cord in the canal to block pain signals that are traveling from the lower back and legs, and acts as a roadblock. So those pain signals basically are stopped before they pass through the middle of the spinal cord and then reach the brain. Oftentimes in the past, patients would feel a tingling or vibration because we were trying to replace that pain signal with something much more pleasant. Well, as we talked about on the last slide, nowadays with the advancements in our spinal cord stimulator batteries, you can block that pain and replace it with no sensation at all. So the patient has pain relief without feeling that tingling or vibration. So if that was a previous concern of yours, whether or not you wanted to try this because you're worried that you wouldn't like the way it felt, well, now you have the option of getting the pain relief without feeling the vibration or tingling. The beauty of spinal cord stimulation above any other type of medical therapy is that you actually get to try it out, and you would know within about 7 days whether or not this is something that's going to be effective for you, whether it's going to be significant in reducing your pain, whether it's going to improve your function, your sleep, whether it's going to reduce your medications. And that's because we have a way of implanting the wires that we use for spinal cord stimulation through a needle into the epidural space temporarily for about 7 days. Those wires are attached to a battery that delivers the exact same type of impulses that the permanent system would deliver. But after those 7 days, those temporary wires are gently pulled out of the skin and thrown away. Those 7 days are important because you get to actually feel how that stimulation would do for you in a real world setting at home, doing the things you normally do. And at the end of those 7 days, when we remove those wires, there's no scar tissue, there's no incisions, there's no sutures. If it worked, fantastic. At that point, you get to decide whether or not you want to have the permanent system implanted. If it didn't work, we're sorry, but you're not left with any scar tissue, you're not left with any incisions, any sutures, and no long-term effects. We at least know that we tried something that was potentially going to be effective for you. Down the road, we won't repeat it unless the technology changes dramatically, but at least we know that there was a trial to see if we can get your pain under better control. So personalization is a very important part of spinal cord stimulation. Not everybody likes the way the stimulation feels, and so the type of waveform or the way the electricity is delivered to the spinal cord and the way the patient perceives it can be personalized to every single patient. And even during the trial, once the stimulator is turned on after I place those wires in the epidural space, the patient can contact the representative from the stimulator company and request different types of waveforms so that, the first couple of days they might feel the tingling. The next couple of days, they might not feel any tingling and just have pain relief. And then there might be a combination of the two for the last couple of days. And so there's a lot of variability, and it's very, very personalized to the patient. We determine which therapy works best. Patients are able to download an app onto their phone where they can place their goals onto the app for what they want to experience during the trial, whether it's the reduction in pain by 50% or more, or whether it's I want to sleep through the night, or I want to take less medicine, or I want to be able to get out of bed in the morning without having to sit on the side of the bed for half an hour before I can move. Whatever the case may be, these are goals that the patient will put into the system, into the app. And at the end of the trial, I can download that and put it and print it out and put it directly into your chart. And that'll be a great way to determine if that's something that we should proceed with implanting the permanent system. So, we're looking at a chart here that documents what patients' normal pain levels are before a spinal cord stimulator is implanted. So I would say that a lot of our patients come in with anywhere between 7 out of 10 pain to 10 out of 10 pain most of the time as new patients. And so you average that out, you're looking at about 8.5. And when we look at studies that show how much better patients do between pre-spinal cord stimulation and post-spinal cord stimulation, we're seeing a very dramatic improvement, oftentimes greater than 70%. And you're looking at these pain scores, which sometimes, when I ask you to give me a pain score, it's really tough to come up with an accurate number. You just know you hurt, and you hurt a lot. Well, if you know how you rate your pain, and then you see that your pain scores are coming down to a 3 out of 10, and you know how you're rating your pain, which oftentimes patients will write 12 or 15 or too high to count, coming down to a 3 out of 10 in a clinical study is a very, very dramatic and significant improvement. So spinal cord stimulation has been proven over and over not just with the current systems, but dating back 10 years, 15 years. The therapy is highly effective and has been proven to be more effective than reoperation for patients that have already had back surgery. So we're at the point now where I know a lot of patients have been texting in questions. I want to start to actually go through those. And I'm going to have Rachel join me. And if there's more hardware questions or questions about her company in particular, she'll be happy to answer those for you. If there's questions about the trial or the implant or the therapy itself, I'll be happy to answer those as well.
For having me. I'm Rachel with Boston Scientific. Works with Dr. Sureja or tonight. We are just going to look in the chat here real quick. Take questions. This shows you how to answer a question. It's under the Q&A. Let's see. I'll let you take.
So the first question we had was, can this therapy help with pain from an old injury, whether it's a spinal cord contusion or something called Brown-Séquard syndrome or fibromyalgia? Well, like we talked about, the goal of spinal cord stimulation is not only to manage pain that's related to arthritis or a herniated disc or degenerative disc disease, but also any type of nerve pain. And so the answer to that is yes, it's always worth a try because, like I said, you get to trial this device for 7 days. Oftentimes, even I don't know the answer to whether or not it'll help your pain. But if it is a nerve-related pain or a spine or nerve-related injury, it's oftentimes very, very likely that it could help your pain. We have another question about spinal cord stimulation and neck pain. I know I didn't really talk much about neck pain. The difference between placing a stimulator in the lower back and the neck is that for back pain, generally we're placing the wires in the thoracic spine where we have a lot of room to place a couple of wires attached to the battery to block pain in the lower back and legs. In the neck, depending on whether or not the patient has spinal stenosis or they've had multiple neck surgeries, oftentimes there's not adequate space to place a wire. And so, you know, every person who comes in with chronic neck and arm pain is a case-by-case basis. I would say that most patients with back or leg pain are going to likely be candidates for spinal cord stimulation. The same cannot be said for patients with chronic neck and arm pain.
Another question about
Yeah, so the new in the past, because these devices are made of metal and the wires that are implanted in the spinal canal are made of metal, there was some concern that the magnetism that MRIs during the scan would interfere with the system, or there'd be some abnormality or issue with using a metallic device along with a MRI. And so before, you know, unless a patient had something that had to be monitored specifically with MRI, like multiple sclerosis or what's another thing that we use? Cancer patients that you have to follow. We would, if you didn't fall into those two categories, generally you would get away with using a CT scan. Now the newest batteries, the newest wires are MRI conditional and are compatible with full body MRI. And so MRI machines that are 1.5 Tesla or less, or the better open MRI systems out there are fully compatible with the newest the newest spinal cord stimulator system. So in the past, where patients would have to decide whether they wanted to continue to get MRIs or CT scans versus their spinal cord stimulator, now they don't have to make that decision. We have systems that work in MRI machines. So one person was asking about spinal stenosis. They've had 2 back surgeries. They're still in a lot of pain and having difficulty walking. Would the spinal cord stimulator help them? Well, just like anything else, obviously, we'd have to see you and do a full neurologic exam, make sure there's no what we consider to be red flag neurologic deficits. We'd probably get a new MRI to make sure that there's no stenosis or narrowing developing above or in different areas than where you had your back surgery, and make sure that this is not just a chronic problem versus a new issue that hasn't been addressed yet. If this is a chronic issue and we don't find anything else that can explain these symptoms, then absolutely patients would be a candidate for the spinal cord stimulator trial. Another question is, what are the risks of the spinal cord stimulator trial? And I can even take that a step further and talk about the surgical risks. And so the process of placing the wires in the epidural space during the trial, which is the part that we do here in the office, is done under live x-ray and done with a epidural needle, the same exact type of needle called a TUI needle that is used to place epidurals for pregnancy. And so using x-ray, we place the injection into the epidural space. The needle is hollow. We can actually slide the flexible wire through the needle. The wire goes into the canal and bounces off and travels up in the canal so that eventually the tip of the wire is placed somewhere in the mid back between the shoulder blade area. That's the part of the spinal cord that corresponds to the lower back and legs that we want to stimulate in order to block that pain. As far as risk of spinal cord and nerve injury, the risk is minimal because we do scans ahead of time to know how much room we have to put the wires in. The patient's anatomy has been reviewed multiple times before the trial. So we know how deep we can place the injection, how high up the wires can go. And so the risk of nerve and spinal cord injury does exist. Is it a real concern? Not really. We haven't really seen much of this reported in the literature. And in general, this procedure is considered extremely safe. Other issues that can arise with any type of injection, not just with spinal cord stimulation, is allergy to the medications that we're injecting. In most cases, this is the anesthetic. It can be bleeding, infection. You have an indwelling wire for 7 days that's shooting through the skin. And so we want to keep that area clean and dry and reduce the chance of infection. Of course, at the beginning of the trial, the patient will receive some antibiotics through an IV. And then during the time that they're at home, they're going to be taking oral antibiotics twice a day to make sure that no skin infections develop that would travel along the wire into the epidural space. Now, after you come back following those 7 days and you determine that your pain relief, this is something you want to proceed with, next step would be removing those wires to get that there's really no further messing with either the battery or the wires. Essentially, it's a place it and forget about the system, and you'll have full control over how it works, whether it's on or off, how intense it is, whether it's tingling or vibrating or no feeling at all. All those different options.
Thank you, everybody. We're so happy that you attended tonight, and we hope that you learned a lot. I know I do. Every time Dr. Sureja speaks, I know I just learn something new every single time. Dr. Sureja is accepting new patients. So if you would like to make an appointment, if you like what you heard today and you want to learn more, or you want to move forward with the spinal cord stimulator process, obviously call our office at 757-596-1900 and choose option 5 to speak directly to a scheduler to make an appointment with Dr. Sureja. And if you've never been to our office before, we're located in the Port Warwick district of Newport News, and we accept most major insurances as well. We'll look forward to seeing you at our next lecture. We'll hope you'll join us again next month, and we'll look forward to having you. So thank you so much for joining us, and have a great evening. Bye-bye.